Okay, this is a case study, and this is a severe case study on the constriction of the bone and how far it could actually go. You'll see on this case how important it is to have an orthodontist that has a CT scan for sure. So this is the importance of having a CT and actually seeing what is actually possible in a natural anatomy that somebody brings, and their concern over what happens over time when the underlying bone holding the teeth in is extremely thin, and moving the teeth. We see some facets from the orthodontics that this person has had, as well as some of these now soon to be recurring long-term problems associated with her situation. I don't know where she started. She's in her 30s right now, and her issue is to address a problem with one of her lower front teeth, and that would be right here on this one here. And it looks like this. This is what she's coming in worrying about. She has major recession going along the front of a lower front tooth. And that lower front tooth has virtually no bone around it. And that's where the gum tissue will recede away from the tooth. Now, she also has admitted that she's also very thorough with her cleaning. So I'm a little suspicious that it also can be attributed to overbrushing. So if you're really an aggressive brush person, she uses a manual toothbrush. I wouldn't recommend that, especially with her. I would recommend an electric toothbrush. And in particular, in this particular case, I normally would refer an Oral-B electric toothbrush, and it has a head that turns back and forth in this rotation. In this person's case, I like the Sonicare. It's more of a whippy vibration in this manner. And the reason why is because with the vibration, I feel with the soft bristle you can get from a Sonicare and this motion, and the Sonicare is more sensitive to pressure. So when you touch it too hard, it stops. The Oral-B might take a little bit more pressure to stop the Oral-B from moving, but a manual toothbrush, you don't really know. You just put more force on it, and you could actually be brushing the gums a little bit harder or harsher, and could be contributing to this problem more than you would like to. So in this case, I would actually recommend the Sonicare with the softest brush head you can get for that. Okay, so let's look at this constriction, this bone constriction. That's a big problem if you're trying to do orthodontics. Even Invisalign here, I would never want to try to move this person's teeth. This is a very challenging case when you actually look at how the bone is hanging on. It's almost a miracle that these teeth are actually staying in. So when we look at these teeth, and we can look at any of these teeth in the front, if we go right down the middle right here, this is actually the tooth here, I believe, that's loose. She has 4 anteriors here. She has a slight amount of periodontal disease. But the first thing you notice is that her root tips are blunt, almost on all of these teeth. And these are teeth that had moved too rapidly in the bone in orthodontics. Now, I don't do orthodontics, so I shouldn't be the one saying too much about it, but there is a problem when you move teeth too fast, and it can clip the tips of the teeth and blunts them out, therefore losing tooth height or tooth length overall. Normally that's not the biggest problem in the world, so orthodontists probably don't worry too much about that. But what I would worry about is if you move teeth too fast, the bone may not catch up or stay with the tooth and actually migrate with the tooth, and you can actually move the tooth right out of the arch of the bone, which is really not good. So this one here, if we look at the slice view here, you can see there's really no bone around this area at all. It's really deficient coming through here. That means if she fell with the skateboard or hit her front teeth in any way, a softball, any sporting event where you actually hit your teeth, this is a real problem. Her teeth are going to get knocked out really fast. So the first thing I would say also here, besides the home care, is if you play any sports or any possibility where you have a threat to any kind of trauma to your teeth, you got to wear a night guard on this one. She says she grinds, but she always wears her retainer, and that's a must for her. But here's the constriction part right here. See how the bone is wide in her jaw, and then it comes around and really constricts quite a bit here, leaving virtually no bone around the actual tooth. And if we go across the other teeth, you see the same thing. Let's go over here. Look at how constricted it is here. This is impossible to do an implant here. There's no bone for implants. Not until you get way down into the jaw, which is way too low. So unfortunately with her, if, you know, in 30, 40 years, there's a possibility of her not having her teeth. This is going to be a monster to try to restore. We hopefully in 30, 40 years have some sort of bone matrix that we can build that jaw up along with the tissue. If we look at the top teeth, let's go right down the middle of the top tooth. Same thing, this real tight constriction right up at the top of base of the root. And you can see how the root looks a little bit kind of funny edged here. And that's from the orthodontics. When the orthodontics, like I said, move your teeth too rapidly through the bone, it clips the tip of the root. So that's what we see here. We have a very large nerve, and then we have very tight constriction right around this root and very thin bone right around. Those are teeth right in the front. And as we move along, we see even less bone even on the back on this one. Same constrictions, same constrictions. One of the doctors here had put in an implant, and I thought, oh my gosh, how did, looking at the front teeth, how did anybody ever get an implant in here? So let's take a look at that in a second. Here's where the nerve is. Right here, coming through the jaw, but you can just see the sliver of bone coming along here and here. So this constriction affects pretty much every tooth in every position of this person's mouth, and can be very precarious, like I said. The implant tooth, let's look at that, is really as good as you could get. There's a little bit of crestal bone loss around it, but I'm okay with that. The gum tissue sealed it pretty well. It's not a big implant, which is what I don't like, is that the diameter is very thin, but you'll see why you couldn't do anything different than what was done to get a tooth back. I guess the only other thing would have been a 3-unit bridge. But in this picture here, there's a lot of distortion, but we can see that there's decent bone here and the implant's up here, but the nerve is right down here, and he got it right between the crestal plates there of that ridge. And it's as big as you're going to get, even though that's a small implant. You can't do any better than this to restore the site with an implant. Like I said, you could have done a 3-unit bridge, but she didn't really need that in this case. Or if she ever has anything fail here or the implant fail, then she still has that option of a 3-unit bridge. Now, let's address what she came in for. She came in to talk about this problem here. And the best reference I could give her is really just to see a periodontist that has a lot of experience in grafting things like this. Now, I don't know a lot about what the longevity of grafts are here. Typically, within 5 years, a lot of grafts can actually melt away. But this is a very small area to cover over, so I think there's going to be a lot of success here. Plus she has good bone height between the teeth here. The tricky part is when you move that tissue away, will you cause further resorption around these other teeth here and cause recession along those? So that's the first concern when you do any surgery. When you release the tissue, you lose a lot of blood supply to that actual tooth. So the second thing is you hope that when you do a graft like this, that you've cleaned this up well, you've created an environment where you hope that that tissue can actually re-adhere to that tooth structure here. If that does occur, then this is going to be a very successful case. If the tissue does not adhere to this tooth anymore at all, you're going to have a very deep pocket, which can cause future problems. But it's still better to have something going across here, even if this starts to melt away and sag. It's still, I would say, really the only thing you could do, but probably really the only best thing you could do to try to keep this from getting any worse, aside from your natural home care, not causing this to get any worse, which is the first advice of to start with a electric toothbrush and a Sonicare. So this is a great little case looking at that bone constriction being a very red situation. Facial bone is very red as well. And this is a very big precaution on recommending anybody to take teeth out here and try to do as much restorative dentistry as possible, and preventative dentistry where you need a sports guard for sure, a night guard, or some sort of retainer for this person as well. So that's great.